So, a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again to our ACTRAC Head and Neck academic classes. Our today's speaker is Dr. Cessal Thommachan, sir. He is additional professor in Department of Radiotherapy, Head and Neck Unit. Hello. At RCC Regional Cancer Center, Trivandrum. Request everyone to please mute themselves. And sir will be speaking on the role of radiotherapy in the management of salivary gland tumors. So we welcome you, sir. You can go ahead with your presentation.
Thank you, Dr. Poonam. I sincerely thank the Head and Neck Surgical Oncology Department at Atta Memorial Hospital, Mumbai, for the invitation. So I will be discussing about the adjuvant treatment of, mainly the adjuvant treatment of salivary gland tumors. I will share my presentation. So I hope you can see my screen. Yes.
Yes, it has started. Yes, we can see, sir.
Yeah. Thank you. Wait. Yeah. Okay, so the role of radiotherapy is mainly in the adjuvant setting in salivary gland tumors. It can also be used in patients who are, say, inoperable disease in highly selected patients. If we have an inoperable disease or a medically inoperable disease in highly selected patients, after explaining that we are not giving the definitive treatment because that's a surgery, then we can consider the radical radiotherapy. And third indication is to consider the patient for a palliative treatment in patients who are considered for palliation. Palliation may be in very locally advanced disease like the patient who have the base of skull infiltration, where you are not planning for a major surgical resection, or in patients who have metastatic disease, either at presentation or maybe at, say, at relapse, distant mets, or the patient who's having inoperable relapse, then you can consider the patient for a palliative radiotherapy. The role of chemotherapy is not well defined in the treatment of in the curative treatment of salivary gland tumors that we will discuss also. So mainly, so you can see that this patient is having this is the normal left parotid gland. This is a normal left parotid gland. This is a mandible. So you can see that. And this is the masseter muscle. So you can see that this is having, on the right side, you can see an enhancing lesion in the deep lobe of the parotid. And when a patient presents with the, say, the advanced parotid tumors, like in certain situations, you can consider that this patient may require an adjuvant treatment from the beginning itself. So you can also counsel, when you take the patient for surgery, you can also counsel in such a way that this patient require, say, surgery followed by a postoperative radiotherapy. Say clinical situations are like if you have a large tumor, like say tumor more than 4 centimeters, it becomes automatically clinically a T3 disease. Patient have restricted mobility, and the patient who have nodes at presentation, and if the FNAC shows it is a high-grade histology at presentation, or patients have present facial nerve palsy. So these are situations you know that you are dealing with an advanced disease, and the patient require a combined modality treatment like surgery and postoperative radiotherapy. And so we all know that salivary gland tumors are major and minor salivary gland tumors. The major are mainly the parotid gland, submandibular gland, sublingual gland. The minor is mainly present. It can be present throughout the aerodigestive tract, in the oral cavity, paranasal sinuses, oropharynx, in nasopharynx, even in trachea. Many sites you can have minor salivary gland tumors. The clinical staging is more or less similar that of the oral cavity, like less than 2 to 4, more than 4 centimeters. You can clinically stage. Then you do a preoperative workup like an FNAC. Then you do an MRI. Then distant metastatic workup. Then you proceed with surgery if it is operable. Then most of the time the patient is considered for the radiotherapy adjuvant treatment based on the HPR. So in the HPR after surgery, so if say, for example, if a 20-year-old female, the FNAC was a mucoepidermal carcinoma, patient underwent a total conservative parotidectomy, then the patient reports to us for adjuvant treatment. So how we proceed? If the patient is having, you look into the local site, laterality which side, histological type. That's very important because whether it is a high-grade tumor, grade of the tumor, that's very important. Then the size, if it is more than 4 centimeters, then that becomes PT3 disease. Histological grade, that's also very important because the patient is having a high-grade mucoepidermal carcinoma, adenocystic carcinoma. The patient will have a salivary duct carcinoma. If the patient is having poorly differentiated, undifferentiated squamous cell carcinoma, adenosquamous adenocarcinoma, They are all considered as the high-grade histologies. They all require adjuvant program. Then the patient has having any perineural invasion, lymphovascular invasion. Then the marginal status is also very important. Sometimes the patient, if this remove the margin, then the extracts, the capsule is intact or not. These are all important for deciding the adjuvant program. Then any lymph node is present. Also, if the patient had undergone a lymph node dissection, which lymph node is involved, whether the patient is involved level 2 or any other lymph nodes. Most commonly involved lymph node in a parotid gland tumor is level 2. Then whether the patient is having an extracapsular extension, how many nodes are involved. So it is mainly the pathologically staged accordingly. Then you decide the adjuvant program. Okay. So if the patient who have, the most important thing is that the marginal status is really important. So the patient is having margin, if the patient cannot be commended, the piecemeal necrosis excision from an outside, or if the patient is having a margin positive, then you have to consider the patient whether revision surgery is possible or not. The patient is having a low-grade, say for example, a patient presents with a low-grade tumor, margin positive, and if the patient is having a tumor size less than 4 centimeter, then whether to consider the patient for an adjuvant program or whether to consider for a revision surgery, then you have to decide on that whether the patient has a revision. If you do a revision surgery, the adjuvant radiation can be avoided. But at the same time, you have to look into whether the post-op MR, maybe after 6 to 8 weeks, then you do an MR. Then if the macroscopic disease is left behind or not, then you discuss regarding whether to go for a revision surgery or to go for an adjuvant radiotherapy. The patient undergo revision surgery. Then if there is a yield, then that's good. If there is a patient is not having a viable tumor, then that may not yield, and you can avoid radiation. At the time, then you have to counsel that there is a small chance for a facial nerve damage. Then coming to my topic proper, that is the role of the cis adjuvant treatment. It's mainly adjuvant radiotherapy. You can see that this is these various series which published in 90s and early 2000. You can see that I will take a few in detail. You can see that those patients are undergone the adjuvant treatment. There is an improvement in locoregional control. You can see that locoregional control, and certain series have shown improvement in survival as well. So you can see that there is an improvement in survival. So I will take few series. This is one of the series that came in 1990 from MSKCC, and the paper from the Armstrong, and the patient published in Archives of the Otolaryngology Head and Neck Surgery in 1990. It included around 92 patients. Patients underwent surgery or surgery plus postoperative radiotherapy. This is not a large series. You cannot draw any definite conclusion from this. But in those patients who have node positive disease or patients of stage 3 and stage 4, those patients who received radiotherapy compared to surgery alone, there is an improvement in survival. You can see that surgery alone, the 5-year survival was only 9.5% in stage 3 and stage 4 patients, and it was 51.2% in patients who received surgery plus postoperative radiotherapy with a statistically significant survival benefit. And that's applicable for node positive patients as well. Surgery alone is 18.7%, and those patients who receive surgery plus post-op radiation, the 5-year survival is 48.9% with a statistically significant p-value. This is another large series from the Netherlands group published in Red Journal in 2005. It included more than 500 patients, and the patients they compared with patients who received adjuvant radiation, or the 79% of the patients received adjuvant radiotherapy and elective RT to 40%. That's also an area of debate whether to consider elective radiation to level 3. Level 4, that I will discuss when we discuss the adjuvant radiotherapy proper. They had a median follow-up of more than 100 months. It showed that those patients who received adjuvant radiotherapy, there is a 10-year locoregional control. There was no survival benefit, but there was a local control. For T3, T4 patients, it was 84% versus 18%. Those patients are margin close. It is our patients have incomplete recursion, 82% versus 44%. Patients have bone involvement, T4 disease, or patients with perineural spread, 88% versus 60%. And these were all statistically significant. And the postoperative radiotherapy significantly improved the regional control in node positive disease as well. And there is no significant delay between surgery and radiotherapy in local control. That's also one point we have to bear in mind when you think about adjuvant radiotherapy. In this classic teaching in head and neck squamous cell carcinoma is that we have to complete the adjuvant program within 100 days. So you start the adjuvant radiotherapy within 6 weeks period, but there is no direct effect on the delay between the surgery and radiotherapy in local control. And that is the Dutch series. Now we will move to the Dahanka series, which is one of the largest series, which included more than 800 patients. The postoperative radiotherapy improved local control significantly in patients with the same parameters like T3, T4, margin close, incomplete resection, bone invasion, perineural invasion, or node positive disease. So these are more or less the indications for adjuvant radiotherapy also. Now, question is that whether it will improve only local control or improve overall survival. That is one of the burning questions. There is no randomized data. Okay, in altogether in surgery and radiation in the salivary gland tumors, the data is now there is no level 1 evidence like a level 1B, like a randomized phase 3 clinical trial to compare any of the adjuvant programs versus surgery alone. But most of them are retrospective series that we have to understand. That's the limitation of the data. The adjuvant radiotherapy, this is a ZIA database which published in 2011. Which included patients who received adjuvant radiotherapy between 1988 to 2005. The multivariate analysis have shown that those patients who had all patients together, if you look into that, the hazard ratio of death is 0.76. It means there is a 24% relative reduction in death in patients who received adjuvant radiotherapy compared to the no adjuvant radiotherapy. And this is more pronounced in patients who have high-grade histology, it is 0.65, and in locally advanced disease, 0.77. So it means in those patients who have all patients together, it is 7.6. In patients who have high-grade histology, it is 0.65. That is a 35% relative reduction in death. And that was quite statistically significant. You can make out that it is. So it means that this group of patients will benefit from patients who receive adjuvant radiation. That is mainly high-grade histology and locally advanced disease. Now the question is that, what about the minor salivary gland tumors? The minor salivary gland, this is a database which between 1988 to 2008 is 20. It is included large the period. It is 1988 to 2008 included 2,200 patients. In those patients who received adjuvant radiotherapy compared to surgery alone, there is an adjuvant radiotherapy. There was a statistically significant improvement in survival. The p-value is 0.02 compared to surgery alone. And the maximum benefit was seen in patients with that. It's previously seen that's a stage 3 and 4 disease, high-grade histology, and patients who have nasopharynx location compared to other sites. Again, this is a national cancer database published in Advances in Radiation Oncology in 2017. It included more than 8,200 patients, more than 8,200 patients. Then they stratified patients into 3 groups, that is high risk, low risk, and intermediate risk. The high risk patients were patients who have extracapsular extension or positive margin. Then patients who have intermediate risk included T3, T4 disease, not positive disease without extracapsular extension, adenocystic carcinoma, lymphoscal invasion, other high-grade histologies. They were included in the intermediate grade, and the patients who have T1, T2 disease, less than 4 centimeter margin negative, they were all considered as low-risk patients. And it was found that at a median follow-up of 42.5 months, the high-risk patients, that patients who have extracapsular extension margin positive, and there was a statistically significant improvement in patients with survival compared to patients who received surgery alone. And what about intermediate risk? The patient is, suppose a patient is having a PT2 disease and patient is having intermediate risk, but the patient should receive radiation. We all know that patient with a T3, T4 disease, patient with high-grade histology, they are all candidates for adjuvant program. But if the patient is having, say, T1 or T2 disease with the intermediate grade, so this is a data which published in American Journal of Otolaryngology in 2019. This is it was a national cancer database which included intermediate grade carcinoma. And the patients who have positive margin and negative margin, the only parameter they evaluated as overall survival. It has seen that those patients have a positive surgical margin in intermediate risk patients. There is an improvement in overall survival, and that is hazard ratio of death was 0.34. It's a huge benefit if a patient who received adjuvant radiation compared to no radiation. So to conclude, the indications for adjuvant radiotherapy in salivary gland tumors, it is T3, T4 disease, node positive patients, high-grade histology. I mentioned what are the high-grade histologies earlier. Then the margin positive patients, and the patients with close margin, recurrent disease. Suppose a patient had, say, for example, if the patient had a T1N0 disease, margin negative, no adverse features, low-grade histology, and no PNI, no perineal NVSI. The patient was kept on follow-up. Then patient, say, recur, say, after 2 years, then it's a planned treatment. The patient should undergo a revision surgery plus a postoperative radiotherapy because of the recurrence. Then perineal invasion and lymphovascular invasion. So the radiation treatment, so mainly in a patient who have margin negative, the patient is having a T3. So for example, if the patient is having a T3 disease, T4 disease, or the patient is having node positive, then generally the dose delivered is 60 gray to the postoperative bed. I will discuss what is postoperative bed. Then 66 gray in margin positive or close disease. If that's a 66 gray, that's a standard dose. Now, the standard radiotherapy technique, it is the intensity moderate radiotherapy. So mainly you have to treat the parotid bed. Say, for example, if it is parotid, or if it is submandibular gland, then you have to treat the ipsilateral submandibular gland. If it's a minor salivary gland tumor, then you have to consider the post-op bed. Then if in a parotid, the main critical structures include the brainstem, spinal cord, the brain, the cochlea, the mandible, the oropharynx, then the oral cavity, and also the contralateral parotid. So these are the constraints, the concerns. So that is the radiotherapy part. Then I will just touch upon, before taking up the technique, I will discuss, is there any role for chemotherapy in addition to radiation in a resected the salivary gland tumors. This is a data published in JAMA Otolaryngology in head and neck surgery in 2016. This is a data from the National Cancer Database, which patients included. Mainly, the question was, is there any benefit of giving chemotherapy in addition to radiation in patients who have resected major salivary gland tumors? But it was found that those patients who received radiation versus chemoradiation, those patients who received chemoradiation, there was a trend towards there's a negative impact. Means there was a reduction, is a negative impact in patients who received chemotherapy compared to radiation. The p-value was not significant, but there was a trend towards the benefit was a negative benefit, the negative benefit. That's the p-value is 0.808. And the question being asked in a RTOG ongoing clinical trial, RTOG 1008 clinical trial, it is a phase 2 phase 3 clinical trial. The patients are randomized between 60 to 66 gray in 30 to 33 fractions, versus in patients with weakly cisplatin, and in patients who have T3, T4 disease, intermediate risk or a high-grade histology, node positive or margin positive, or patients with adverse features are randomized between radiotherapy versus chemoradiation, to stop chemoradiation. This is an ongoing clinical trial. So to conclude, there is no benefit for chemotherapy in the adjuvant setting along with radiation, unlike in the head and neck squamous. We believe that in those patients who have extracapsular extension or margin positivity, the patient will benefit from post-op chemoradiation. Now, coming to little bit technique. Okay, this may be a little boring for you, but I will take through that. So one of you all advocate that the facial nerve sparing surgery in the parotid gland tumors. We also believe that one of the critical structures, other than it is the cochlea, when you give radiation, you have to spare the cochlea. So this is a UK attempt that's by Professor Christopher Nutting from Royal Marsden Hospital. It is a multicentric randomized clinical trial of cochlea sparing IMRT versus conventional radiotherapy in patients with parotid gland tumor. There is a COSTAR and there is a guideline based on that. There's COSTAR guidelines for the contouring of the parotid gland. We follow that. So then this is mainly you have the cochlea here. And then if you give 2D radiotherapy, invariably this cochlea will be increased. This will be included in the radiotherapy portal. But when you use an IMRT, you can spare the cochlea. That's called the cochlea sparing IMRT. So this is a UK COSTAR guidelines. It's mainly for the parotid cancer. And although the trial failed to show that the cochlea sparing can reduce the hearing, this is not significant basis IMRT basis 3-dimensional radiotherapy, but this was the concept. So based on that, we contour the patient. So if you have time, then I will take you to the radiology also after the presentation. So CT stimulation, there we all do that after the surgery. Then we will counsel the patient for adjuvant radiation. Then we have to counsel the duration. It is mainly 60 gray in 30 fractions. So it is for 6 weeks. You have to consider the dental prophylaxis before the planning of radiotherapy. Then during simulation, you give contrast. The neck is extended. From you use a 2.5 to 3 mm slice. So CTV1 and CTV2. CTV means clinical target volume. That one includes the parotid blood plus areas at risk. Okay, so that is mainly you include the retropharyngeal node, the 1B node. So generally 1B is not included, level 2, 3, 2A and 2B nodes, ipsilateral. So that is the CTV P1. So then CTV P2, that's if that is optional. We all know that whether the patient should undergo the elective neck dissection in parotid tumors, that's also a matter of debate. So there are two schools of thought. Okay, so in the same way, in radiation also, whether the patient should undergo a elective nodal radiation. Suppose if the patient is having a node positive, a level 2 involved, then level 3 and level 4 will receive, because the entire neck. You also do a comprehensive neck dissection. In the same way, we also treat the level 3 and level 4. But if in a node negative patients, we generally do not treat the level 3 and level 4. We treat only the level 2 region along with the parotid bed. So this is the COSTAR guidelines. It may be a bit boring for you, but I will just go through that. So we'll start from the level of the zygoma, because that's the superior limit of the parotid gland. Inferiorly, it is up to the caudal edge of the hyoid bone. The caudal edge of the hyoid bone forms the inferior border of the level 2 region. It also forms the inferior caudal edge border of the level 1A and 1B also. That's the caudal limit of this one. Anteriorly, you generally take up to the anterior border of the masseter. Posteriorly, I will take up to the mastoid. So this is I will take you through that. So you take at the level of this is the masseter. You have to take the masseter. Then the anteriorly, medially it extends into the infratemporal fossa. Laterally it is the skin. Posteriorly it is the posterior attachment of the pinna or the mastoid. This is a mastoid. Then you have to, at the level of the external auditory canal, this is at the level of the external auditory canal. This you can see that. So you can see this is a mandible here. This is a normal parotid gland. This is a masseter here. This is the insertion of the temporalis muscle getting inserted into the coronoid process, the superior and medial surface. Then you have the condylar process. This is a lateral pterygoid muscle. Lateral pterygoid muscle is originating from the lateral surface of the lateral pterygoid plate. This is a lateral pterygoid plate. This is a medial pterygoid plate. Then you have the parapharyngeal space here. This is a normal site. On the involved area, you can see that this is the anterior border of the masseter. So you have to take the anterior border of the masseter. Then you have to take the pterygoid muscles. You have to include the parapharyngeal space. That's a bed. Then you have to posteriorly, you have to cover the retropharyngeal nodes and also the fascia anterior to the skull base. So this is the posterior limit. Then you go up to the mastoid process. So this is the limit. Laterally, it is the skin. This is that's how we contour. You have to include the retropharyngeal nodes, retrostyloid lymph nodes, the parapharyngeal space here. This is a medial pterygoid muscle getting attached to the angle of the mandible here. This is a masseter muscle. Again, this is a posterior mastoid. Then you have to include the skin here. Then anteriorly, anterior to the masseter. Then you can see this is the parotid duct. Okay, so you can include this entire area into that area. Then lower down, it is lower down at the level of the mastoid air cells. This you can include that area here. Again, anterior to the masseter here. This is a medial pterygoid muscle. It's lower down. It is getting attached to the angle of the mandible here. The parapharyngeal space here. You have to include that area. Then you have if you have a facial nerve is one, then you have to include the stylomastoid foramen between the styloid process and the mastoid. Then you have the stylomastoid foramen. You have to include that area also. Lower down, you have to include the level 2 lymph nodes also. So you can see that this is the sternocleidomastoid here. This is a normal parotid gland. You have this is the sternocleidomastoid here. This is sternocleidomastoid. The posterior edge of the sternocleidomastoid is the posterior edge of the level 2. Then you have to include that area as well. The inferiorly, this is the level 2. This is the you can see that This is the sternocleidomastoid, the medial edge, the anterior edge of this is the submandibular gland. Then the anterior limit of the level 2 is formed by the posterior edge of the submandibular gland. One of the lateral boundaries is the platysma here. This is the platysma muscle here. Then you have the medial sternocleidomastoid here. So medial edge of the sternocleidomastoid forms the lateral boundary of the level 2. Then you have the posterior edge of the level 2 that forms the posterior boundary of the level 2. This is the scalenus muscle. Medially, it is the internal carotid artery and also the scalenus muscle here. Scalenus muscle forms the lateral bound. This is the scalenus muscle all form. This is the level 2. So that also forms the boundary of the level 2. Then inferiorly, you have to take up to the caudal edge of the hyoid bone. Okay. So then in a styloid mastoid, if you have you have to take the styloid mastoid foramen in the patient who have a perineural invasion or if the patient is having a facial nerve involvement. In bolus, you have to include bolus if the patient is having a skin involvement, a superficial, close superficial margin, or there is a tumor spillage. This is one of the patients. This is the upper, this one. This is how we contour that. This is tumor bed. This patient had a skin involvement, so you have to put a bolus also. This is the internal carotid, internal acoustic meatus. So if you are interested to learn the radiological anatomy, so this is at the level of the little below the level of the base of skull. You have this petrous bone here. This is a clivus here. So this is the carotid canal here. Then you have this a mandible, this temporomandibular joint here, the mastoid process here. So this is the internal acoustic meatus here. Then you try to spare the carotid artery, the cochlea here. So this is how you spare by giving 60 gray to this area. So this you have to put a PRV also to the cochlea. So if this is something like the 5880, that's a 98% of the 60 gray given here. Now the question is elective nodal irradiation, whether to consider that. If the node is positive, I told you in the beginning, then you have to treat the level 3 and level 4. Otherwise, it's optional. Okay, there can be two schools of thought. If the patient is having a high-grade histology, the patient is having a T3, T4 primary, then you may avoid. You may add. Okay, it's optional. In that situation, you will give 50 gray equivalent dose. You cannot categorically say that you will treat. Generally, I do not treat, to be very honest with you. But if the patient is having this a squamous cell carcinoma, it's very rare in parotid. But then these are situations like I may consider treating the level 3 and level 4 region. So if you treat, we generally move to the IMRT. Generally, we do not use the two-dimensional radiotherapy planning no more. But in those patients in the era, we used to give the two-dimensional radiotherapy. I just want for the sake of the two-dimensional radiotherapy planning. So this is superiorly, it is the level of the zygoma. Posteriorly, the mastoid. You take the mastoid tip. Anteriorly, the masseter. You take, this is the masseter. Patient lie in lateral position. This anterior border of the masseter here. You have this the parotid bed. Also include the pterygoid muscles here. This is the medial pterygoid here. Then you have the parapharyngeal space and also the retrostyloid, retropharyngeal lymph nodes. So this is the two-dimensional radiotherapy planning. When you use two-dimensional radiotherapy, the issues here are, one, the dose to the cochlea will be high. The dose to the brainstem, brain will be high. Dose to the eye or superiorly. Then also to the oral cavity, and also the opposite parotid also will receive small dose. So if you use an IMRT, you can spare the oral cavity here. We can spare the constrictors lower down. You can spare the brain stem here and spinal cord lower down. Then you can spare the dose to the cochlea. You can spare the dose to the brain as well. So dose distribution in a two-dimensional radiotherapy planning, it's a 95%, that is the 57 gray when you're prescribing 60 gray. So I'm concluding the parotid part. So that is mainly so in T1, T2 with favorable histology and no adverse features like T1, T2, margin negative, no PNI, no lymphovascular invasion, and the nodes are negative, then generally this patient do not need an adjuvant treatment. You keep the patient on follow-up. In T3, T4, high-grade histology, that is up to you to decide. Okay, this is I prepared for a general talk. The ipsilateral level nodes are always included. That is in patients of 60 gray, generally we treat level 2. I have shown you that. Level 3 and level 4, if the patient is having high-grade histology or T3 or T4 disease, Recurrent tumors, even if it is T1 or T2, must receive postoperative radiotherapy. No role for a concurrent chemotherapy along with postoperative radiotherapy as of now. And the cochlear sparing IMRT remains the standard of treatment or the state of the art in the postoperative treatment of the parotid tumors. Then, if you look into the submandibular gland and the minor salivary gland tumors, we follow the basic principles. Same, we have to treat the ipsilateral, the submandibular gland, and if the nodes are there, you have to treat the 1B region because that's a submandibular. Invariably, 1B will be treated. If nodes are there, then you have to treat the level 2. That is very rare. But it can occur, but it is less. Then in the minor salivary gland tumors, mainly you have to follow the same principles like that other sites. In same principles, you have to, most of them in minor salivary gland tumors, they are high-grade histology, they require radiotherapy. So generally, they are, you give surgery followed by postoperative radiotherapy. So if you have, if you are interested, you read through the ASCO guidelines. It includes the initial evaluation from FNAC, imaging, the types of surgery, and also the adjuvant program is discussed. That came in 2021, the management of salivary gland tumors ASCO guidelines. Thank you very much for your patient listening. If interested, I will take you through a few situations like, say if a patient is having, say, a 20-year-old girl underwent, yes, 20-year-old girl underwent, say, surgery, then if it is PT1, T2 disease, margin negative, and all other adverse features are negative, we said we will keep the patient on follow-up. On the other side, if the patient is having a more than 4 centimeter, patient is having high-grade histology, patient have node positive, and the margin is positive, then generally you go for the postoperative radiotherapy. There is no doubt in that. There are some dilemmas. If sometimes the patient was referred after a piecemeal excision or the margin is positive in low grade, then it needs discussion, the proper radiological evaluation. You have to discuss regarding adjuvant radiation or a revision surgery to avoid adjuvant radiotherapy. Then can I take, if you have time, then you will take the questions now, or I will take, if time permits, I will, can I take, yes.
Yes, sir. Sir, what exactly you are asking for, sir?
No,
Hello?
I was thinking of taking a case situation. Okay.
Yes, sure,
Okay.
sure, sir. Please do it, sir.
No, I don't have a case, but I can take the radiology part. So whether I will be able to open the packs. Okay, that's the question. Okay, just in the laptop, whether my system, the hospital packs is possible. Sometimes it is possible. Okay. Are you seeing my screen?
Not now, sir.
Okay. I will do one thing. Give me 1 minute. I'm loading to that. I'm logging. In the meantime, I can take any questions. If you have any questions, please.
Yes, sir. There are a few questions. Shall I read it to you, sir?
Yeah,
So,
of course, please.
yeah. So, sir, can you please explain the hazard ratio once more?
Yeah. Hazard ratio means, if you have the hazard ratio means it's a parameter whether you look whether benefit or not. Okay. So this it's not, there are two things are there. There's absolute benefit and there's a relative benefit. Okay. If the hazard ratio is 0.8, means there is a 20% relative reduction in death. So if it is for hazard ratio of death, this hazard ratio can be hazard ratio of recurrence also. The hazard ratio of recurrence is say 20%. It means the patient is having a 20% chance of less chance for relapse. Okay, so that is a hazard ratio. Give me 1 minute. Okay, then okay, I am taking a CT scan. I'm checking a CT scan. Okay, cancel CT scan last search. Actually, I logged in while my presentation. If it is then I logged out automatically from the Just give me a minute. So I will share. Can you see the CT scan now?
Yes, sir, we can see.
Okay. So this is not a planning CT. I tried to log in the planning from the TPS, but it was not possible. I'm sorry for that. I wanted to show you from but situations, but I will show you how to look. So when you see this, if you have time, can I take another 10 minutes?
Yes, sir. Sure, sir.
Yeah. So you see, this is the parotid. Okay, I will lower down. I will trace from you for you. So this is the parotid gland. Okay, so very simple. It is a parotid gland is between the mandible and the mastoid. So this is you take the mandible and the mastoid. This is a parotid gland. Then you can see the parotid, the anteriorly duct. Okay, this is a masseter here. Then okay, it is not that clear. Okay, so that is a parotid. So you know that the parotid is having a superficial lobe and a deep lobe. The deep lobe is very close to the parapharyngeal space here. Lower down, when you take from the up, okay. So this is the level from where you start seeing the parotid. You check for the parotid. So from the zygoma, you have the zygoma here. So then lower down, you can see that this is the parotid gland. Okay, see that this is a parotid gland. So this contrast is also not that good. Okay, I have not, I'm not. So this is the masseter here. This is a mandible here. So this is a maxilla. This is a pterygoid plate. And you have the, this is the parapharyngeal space here. And then this is the medial pterygoid. You have to look whether it is a medial pterygoid or lateral pterygoid, how you look. The lateral pterygoid is more like a horizontal, like this is the pterygoid plate, this is the lateral pterygoid plate, this is a pterygoid fovea. Okay, it is getting attached to the condylar process of the pterygoid, and this is the temporalis muscle. Temporalis muscle, this is getting inserted into the coronoid process here. Then it is going up, okay, and it is getting arising from the infratemporal, so the crust of this one. So that is the muscles here. Lower down, you can see this is the medial pterygoid. Medial pterygoid plate arises from the medial surface of the lateral pterygoid plate. You trace it down. So this is the medial pterygoid plate getting attached to the angle of the mandible. Okay, this is the angle of mandible is getting attached here. So that is when you contour that, lower down, you go up to the level of the, this is the level 2. Level 2 starts from the C1 vertebra, okay. This is the posterior belly of the digastric here. This is the posterior belly of the digastric. The anterior border superiorly in the level 2 is at the anterior extent or anterior end of the posterior belly of the digastric. Laterally, it is the medial edge of the posterior belly of the digastric. You can make out that. Then lower down, once the submandibular cease, the submandibular gland forms the posterior boundary of the level 2. Then medially, it is the internal carotid artery. Posteriorly, it is the posterior edge of the sternocleidomastoid. A parotid gland also forms the lateral boundary of the level 2. The lateral boundary of the level 2 is formed by 4 structures. One is the posterior belly of the digastric. Second is the parotid gland. Then you have the platysma. So platysma also forms the lateral surface boundary of the level 2. Then the medial surface of the sternocleidomastoid, the 4 structures. Then these are the structures which form the this one. This is a hyoid bone. You can see the hyoid bone here. This is a submandibular gland. The lower end of the 1B node is at the level of the lower end of the submandibular gland or at the lower end of the hyoid bone, which is lower. So this is a hyoid bone here. You can see the vallicula here on either side. This is a median glossoepiglottic fold here. This is a lateral glossoepiglottic fold, also called the pharyngoepiglottic fold here. Now you can see the submandibular gland is slowly fading away. So this is the hyoid bone. the caudal edge of the hyoid bone. This is the lower limit. Okay, this is the hyoid bone giving away, and you can slowly start seeing the thyroid cartilage. Okay, so this is a hyoid bone. This is a lower end. So lower end of the hyoid bone forms the lower boundary for the contouring of the parotid gland. Then the other structures. So this is not beyond the scope, so I am not discussing that. So superiorly, we contour from the hyoid here and lower down on the way, all the way down to the caudal edge of the hyoid for the parotid. For this submandibular gland, I will take you that. Okay. So submandibular gland, this is the submandibular gland. This is the mandible belly of the digastric. Okay. The lateral boundary of the medial boundary of the level 1B is found by the lateral boundary of the anterior belly of the digastric. So this area we need to contour. This is a platysma. So this is the area for the submandibular gland. Okay, lower down you take up to this area because that's the caudal edge of the submandibular gland. All the way you take up to the area where you see the contralateral submandibular gland, because the ipsilateral submandibular gland will be removed. So how you look for the submandibular space? Very simple. You take the mandible, you look for a hypodense area here. So this is due to a tilt. You can see that this is a hypodense area here. All the spaces are hypodense in CT and hyperdense in MR. So you can see this area is the hypodense area here. This is a submandibular gland, and this is the submandibular 1B space. This space you can see that. The sublingual area, so I will take up that area also. This space is called the sublingual space. So you can see that. So you have this muscle is called what is that called? The genioglossus muscle. Genioglossus muscle is arising from the superior genital tubercle in the mandible, and it is getting attached to the extrinsic muscles of the tongue, and few fibers getting attached to the hyoid bone. That's a midline structure. Then you have this is the lingual septum, the hypodense area. This also contains fat. On lateral to that, you have the sublingual space. So this area, the hypodense area, is called the sublingual space. That's very clear in that is very clear in MR, but it is not that clear in CT scan. So this area contains the sublingual gland, the duct, the submandibular duct, the lingual nerve, and the lingual vessels are seen in the sublingual space. Okay, so you take that area also down. So this is a sublingual. You are seeing that the sublingual space. So this is sublingual space. You trace upwards. This is a sublingual space. Okay, that's a sublingual space. Sorry for not showing you a real the planning. Okay, any questions? I'm happy to take questions.
So there are a lot of questions. So the next question was, in case of distant metastasis, we have to directly go for chemo.
Yeah. So that is the question is, if the patient, that depends on many factors, the histology. The patient is having an adenoid cystic carcinoma, they have a very intolerant course. Okay, if you have a very small lung metastasis, small primary, then you have to discuss with the patient, saying that, okay, whether to proceed with it, because most of the time the problem is going to be with the local problem, okay, local issues. So you have to discuss, you have to individualize that situation. So in head and neck squamous cell carcinoma, we agree that if the patient is having a distant man, if the patient is having any node in the mediastinum, then this generally go for a stage 4 disease. In salivary gland tumors, you have to take a call. Okay, I will give you an example. The patient is having a adenoid cystic carcinoma. If it's only one met is present in one lobe of the lung, then you consider the patient you discuss the situation with the family. The patient is having bilateral mets, then I will be tempted not to consider the patient for a radical approach. Okay, so the question is that in that situation, you are not considering a radical approach. The question is that whether to consider the patient for a systemic treatment or whether to go for a local palliative radiotherapy or palliative treatment. That's again a matter of concern, because if the patient is asymptomatic, the response to the chemotherapy in a metastatic salivary gland tumor is also not that good, like this squamous cell carcinoma. Its response ranges from 10 to 13%. So you cannot categorically say that there will be a huge impact by starting a systemic therapy. Okay. So you have to individualize the situation. So you cannot clearly say that, okay, it should be considered for palliation, or you have to individualize each situation. Okay. Yes.
Another question, margins are same as that in oral squamous cell carcinoma, that is 5 mm, or like, I think the question is like, how do you consider the closed margins in
Okay.
salivary gland?
Same. Salivary gland tumors, if it is more than 0.5, this margin is negative. 0.1 to 0.5, you consider this closed. Or in margin is positive, then margin is positive. Yeah.
So, sir, the question here, I think, is quite relevant in the sense that in cases of especially parotid tumors, as we know that the facial nerve is always going to be the limitation, even with free margins, and many a times we'll end up having closed margins like 2 or 3 which is more often than uncommon. So, Sir, how do you plan in those cases? If it is like a mucoepidermoid carcinoma, then how do you plan it? I understand if it is high grade, we are going to radiate, but how are we going to do it if it is like a low grade tumor, like low grade mucoepidermoid, and other parameters are okay? So how do you plan, sir, that?
I will take a scenario like if it is a T2, T1, T2 disease, low grade mucoepidermal carcinoma, and the margin is 0.2, and all other no other adverse features are there. There's no point in doing a revision surgery. Whether the patient will benefit from adjuvant radiation, I don't know, to be very honest with you. So we will discuss in that situation. Even if we discuss in tumor board, we cannot solve it. Okay, we will discuss with the patient whether the patient can come for a close follow-up. The morbidity, I will explain the morbidity of radiotherapy, especially if the patient is a young patient. But at the same time, it is only 0.2. So you have to take and negotiate in that path with the discussion with the family. So patient should understand that this patient had margin is not that it's close, but the patient should be ready for whether the patient is the patient. Some patients say, come across some patients, especially in Kerala, many patients work abroad, like Middle East. And I know that this patient may not come back. So generally I treat the patient. It may be an over treatment. But if the patient is can follow up the patient, there's no clear guideline in this situation. You have to individualize and also discuss with the family. Then the morbidity of radiotherapy, then it is not positive. It is only 0.3 centimeter. So it is okay. We tried because it is very close to the nerve. Then you have to take a call and then you discuss. It's a combined decision to whether to go for proceed with radiotherapy after explaining their excess morbidity and whether the patient is willing to for a close follow-up. Yes.
So there is a case, some student has written that they had a case of mucoepidermoid carcinoma, and the pre-op imaging showed the compression of deep lobe due to the mass effect. Pre-op facial nerve function was normal, and intraoperative the facial nerve was involved. The upper trunk and deep lobe were involved. And since they did not have the consent to sacrifice the nerve, they were not expecting the nerve to be involved. They did a superficial parotidectomy and they did a lymph node dissection with one node being positive. So the patient is now not consenting for the completion parotidectomy. How do you consider it for adjuvant RT only?
Ideally, the patient should undergo a revision surgery because I understand that the macroscopic disease is left behind. So ideally, the patient should undergo a revision surgery followed by a planned postoperative radiotherapy. But it is not possible, then we have to consider this patient. If most of the time the patient may not be willing to undergo a revision surgery because we also have to explain the chance for a facial nerve damage because it is there. So in that situation, then you have to consider for a radiotherapy. Then we will not add chemo because there is no data, but we will increase the dose to a 66 grade, the macroscopic dose rather than a 60 grade dose. And also we'll trace up to the styloid foramen for that. And also in that also, if you have a preoperative MRI, then whether the patient is, what about the internal acoustic matters, everything you have to take in that consideration, whether the perineural invasion is present in that situation.
Sir, there is another question. When the tumor is confined to superficial lobe, adequate parotidectomy was done, but margins were less than 5 I think similar question. So should we go for total parotidectomy or adjuvant RT? I think we discussed it already, sir.
Yeah. So if the patient, my thought process is very simple. If the patient is having low-grade tumor and if it is T1, T2 disease, if you have a 0.5 centimeter, margin is negative, you have done a superficial parotidectomy, that's fine. Okay, but if the patient, most of the time, what will happen is that the patient will have a deep lobe involvement or anything is there, then you may better to consider a total conservative parotidectomy, you do a revision. But in that situation, we discussed whether if it is closed, what should be done. Okay, yes.
Sir, I had a question. Like you, in your presentation, showed that the delay in RT is not similar to that in our other head and neck cancers. So, sir, how is that? Like for head and neck cancers, usually we take that the RT needs to be started from 6 to 8 weeks.
Yeah,
Usually, 6 weeks is the standard time. So, because to counter
complete
the
that.
repopulation of cancer cells, does not that not work similarly in salivary gland tumors?
No, ideally, in all the practice, we should start within 6 to 8 weeks. I said in that paper, what they have evaluated that what they have done is that the patients were compared with the patients who have started within 6 weeks, completed within 100 days versus not. But there was no difference. So you cannot take that into clinical practice because it was a retrospective data. And we can, as of now, we have to say that generally we have to stay. But if the patient, say, for example, if the patient say, how I take it in the practice is that I will not suppose if the patient is done a total conservative parodactomy outside and patient is reporting after say 6 to 8 weeks, still I'm not that worried compared to a squamous cell carcinoma. That's the only message I want to say. It doesn't mean that you should not start. Okay, we should start within 6 weeks, but the threshold may be little may be different compared to a squamous cell carcinoma compared to a salivary gland tumor.
No, so why I was asking this question is because in our routine practice also we see a lot of patients, they operate parotid tumors or other tumors, and then the patient comes to us after 2 months or 3 months even. So and then the patient needs most of the time some sort of adjuvant radiotherapy. So how should we go ahead in those cases? That was the question.
My thought process is very simple. Okay, so up to 12 weeks. Okay, for all these situations, I will consider. Okay. So 12 weeks, if a parotid tumor comes within 12 weeks, that's say 3 months. Okay. Up to that, I will consider adjuvant radiation. But it is beyond say 3 months, then I will discuss with the family. Okay. Then I will do a repeat imaging. Then there is no disease there. Then after explaining that this delay can impact on the local control, then I will consider radiation.
Okay, sir. Sir, last question. What like we used to read earlier, like neutron therapy and others. So, is there still neutron therapy just to complete for the sake of completion?
Okay,
It is
so that
relevant.
was a data in Western
And what
data
about the
that
proton therapy, sir? What is the, it is?
proton is the neutron because it was inoperable parotid tumors. Generally, the previous thought process was that the neutrons were used. No more, it is not practiced. In patients who have a palliative treatment, say if you have a patient with a base of skull involvement, you feel that you cannot attain an R0 resection, you feel that it is, or the patient who have a, say for example, a minor salivary gland tumor in the palate with extensive cavernous sinus involvement, you feel that you cannot resect and the surgery may not yield that. So you go for a palliative radiotherapy in that situation rather than going for any other gadgets. Okay. Then the proton is a new thing which is coming up. Okay, but you cannot clearly say that because we are with the VMAT, the present IMRD itself, we are able to give a good sparing of the critical structures like the patient cochlea sparing and the brainstem, the brain, the all other is possible even with the new the VMAT. Even the proton may not be. So I'm not sure whether the proton will have an impact in reduction in morbidity. It should be tested in a phase 3 randomized trial. Without that, you cannot clearly say that, okay, proton may be better compared to photon in the adjuvant treatment of salivary gland tumors.
Correct, sir. We need to generate data to because still it is early. So I think with this, sir, we conclude today's lecture. We are really thankful. It was just a great lecture, and I, in fact, learned a lot. And sir, you patiently answered all these questions. And I look forward to have you sometime again for these classes.
Sure.
Thank you so
My
much.
interest include radiology. If you're interested in radiology, we can have discussion on that because that's the area where I'm more interested. Okay. Yeah. Thank you.
Thank you so much, sir.
Thank you. Thank you very much. Yeah.